Hello and welcome to Best of the Day from the 50th annual meeting of the American Society of Clinical Oncology, coming to you once again from Chicago, Illinois. So it's been a busy, crowded, hectic meeting as usual, but we're sitting down this afternoon to talk with Dr. Rob Dreiser from the Cleveland Clinic about some of the interesting abstracts presented and discussed at this year's meeting regarding prostate cancer, bladder cancer, and renal cell carcinoma. So Rob, once again, thanks to you for coming to Best of the Day. We always appreciate it.
Well, we've been doing it for 50 years. We should keep going, right?
Yeah, I guess.
Okay.
I guess. So let's begin with prostate cancer. And there were a couple abstracts, I think, very important in early prostate cancer. One was regarding immediate versus delayed androgen deprivation therapy in patients who are beginning to fail with rising PSA levels. And then the other abstract made the plenary session. And that was a very large study on overall survival for patients who definitely had metastatic disease, some high volume, some low volume, but they were still hormone sensitive. So do you give them androgen deprivation therapy, or do you throw in several cycles of docetaxel as well? So let's start with the immediate versus delayed. What was your take on that abstract, and how does that change practice?
So that work came out of the Harvard School of Public Health, and what they did was they used the CAPTURE database, which is a big sort of mixture of clinical and academic urologic practice that's sort of generated out of the University of California, San Francisco, well-known, well-used database. And they addressed the question about early use, so in the non-metastatic sense, of ADT versus using it when the patients had more advanced disease. So this is not a prospective study per se, but it is a prospectively collected data set. The take home, I think what made this analysis unique was they used some very sophisticated statistical techniques to account for a lot of the bias and variability across the spectrum in terms of how patients present and how they're managed. The take-home message was there was no difference in improvement in either prostate cancer specific or overall mortality in those patients who received early hormonal therapy. One of the things I think that, again, while this is not a definitive prospective study, and in fact there is a randomized trial testing this hypothesis that's being done in Australia. That trial is going to take probably some time before we see the data. But the reality is it adds to the body of literature to tell us that the treating patients with primary testosterone suppressive therapy, with all the morbidities that we've now really become very familiar with, the metabolic syndrome, issues of osteoporosis, changes, hot flashes, all those things, in the average patient with biochemical failure, we're not doing them a service by managing them earlier with androgen deprivation therapy. So I think what this provides us with just another chink of data to say, we need to be a lot more thoughtful about managing these patients with PSA failure, many of them who will do well for long periods of time.
So what would be your triggers for then initiating ADT in someone that you've been watching with a PSA failure, but they've generally been doing well? Is it a matter of symptomatology, objective evidence of metastatic disease, positive bone scans, or when do you feel it's important to step in?
The PSA failure patient is obviously complicated and somewhat different if the patient's had a radical prostatectomy versus radiation therapy. But in general, for a patient who's asymptomatic, one looks at the parameters. I mean, if you had a Gleason 10 patient who has a PSA doubling time of 2 months, that's not the same kind of patient as somebody who's 2.5 years out from prostatectomy, maybe got salvage radiotherapy, now has a PSA doubling time of 14 months. So I rely on doubling time using at least 3 values. And again, I'll remind people it's a logarithmic equation. It's not just doing the math in your head. And I look at doubling times, and when it begins to dip below 6 months, even in the asymptomatic patient, I may image because I'm worried about occult metastasis. But if I'm following a patient, many of them who have very prolonged doubling times, not that worried, and they don't really require imaging. So there's no absolute straightforward answer that covers the spectrum, but for many patients, doubling time is again, in the absence of symptoms, is a reasonable parameter.
So if you're watching someone with a PSA relapse, how do you decide how often you want to measure that PSA? Do you go by what their original Gleason score was, or how reliable they are as to when they come back?
Again, we like to avoid oversimplification, but the majority of my patients, I will assess PSAs at 3-month intervals.
Okay.
Now, is that the absolute right answer? I don't know, but is it a reasonable interval? I think so.
So there might be some you do it more often, others you do it less
honestly,
often.
very rarely would I assess PSA more frequently than that. If I'm
Very
that
good.
worried about it, then there's something else going on that would probably trigger me to do something different.
All right, so now some of these patients have progressed.
Right.
They've got objective evidence of distant disease. Their PSA is doubling rapidly. It's time to initiate therapy. Do you give just standard ADT, or is there a new standard with the addition of docetaxel?
So I think there is a new standard. I think among the most important papers presented at the meeting was the ECOG intergroup trial presented by Chris Sweeney at the plenary session. The study design was relatively straightforward. Patients with metastatic prostate cancer who had not received hormonal therapy, so these are either patients who walked into the clinic with metastasis or you've been following, did not give hormonal therapy to, develop metastasis. Those patients were randomly assigned to either get primary hormonal therapy, either with just monotherapy with combined androgen blockade, versus the same therapy and 6 cycles of docetaxel without prednisone. So using prednisone pre-medication, but not daily prednisone. That was the randomization. So this study was, its first interim analysis was stopped, and this was preliminarily reported by the NCI because it was an NCI-led trial a couple of months ago. So what we saw yesterday was the full data set. And let me just try to put into perspective how important the finding was. In those patients deemed to have what we call high volume disease, that would be defined as having 4 bone metastases in the spine or pelvis, plus at least 1 bone metastasis outside of that location, or 4 bone metastasis plus visceral disease. That subgroup, which represented about 2/3 of the patients, had a 17-month improvement in survival in those patients who received chemotherapy plus hormones compared to hormones alone. 17 months.
That's
improvement.
huge.
This is an unbelievable, although I believe it, an unbelievable impact on using a conventional therapy and bringing it earlier. I mean, let's just reflect for the moment. All of the novel new therapies that have been developed, very important therapies, enzalutamide, abiraterone. These therapies, critically important, have median improvements in survival in 4, 5, 6 month range. 17 months of improvement. So to me, today, for a patient who fits the criteria of high volume disease, I believe, based on the data that we saw yesterday, that androgen deprivation therapy plus 6 cycles of docetaxel is the standard of care.
Now, there seemed to be a difference between the low volume and the high volume disease. And Michael Morris, in his discussion, talked about, there are some high volume disease and then there are some high volume disease.
Right.
And so what will be your cutoff in the years to come?
Yeah, and I think the good Dr. Morris made an excellent point. And some of the definitions that were used, high volume, these are, I think, rational, but albeit somewhat arbitrary. I think a patient who presents with nodal metastases only is not likely to be somebody I'm going to probably present this data to and treat. Mike showed some pictures and some bone scans, one where a patient had a single bone met, but it covered his entire hemipelvis.
Right.
I think that's a patient that I'm going to offer therapy to. So there's going to be some gradations. Obviously, it's going to be driven, if you have a patient who has a Gleason 10 who has 3 spine mets, I suspect that I'm going to offer that therapy, even though that wouldn't technically have fallen. So I think there's going to be a bit of clinical judgment.
Individualization.
The lower volume patient is not such that we can say that we wouldn't do it, or because the data, it's too early for those patients. We need a little bit more follow-up. So it may turn out that with more follow-up and more events, that we'll do it with everybody.
Right.
But for now, I will restrict my use of docetaxel in that setting to high volume / high risk patients. But there's still a lot of those patients.
Yeah, it's really interesting.
It's a fascinating,
well done study.
It's one of those examples where a lot of times the cooperative groups come into criticism, and we're in a crisis mode with funding of the cooperative groups. This is a reminder that practice-altering data comes from doing clinical trials, And this came out of the cooperative groups. ECOG and SWOG did this trial together and provided an important piece of data.
And it had to be. This was not a study that was
would never
ever
been
going to
done-
be industry supported. It had to be done through the cooperative groups.
Absolutely.
So you mentioned abiraterone acetate and enzalutamide, and there are several new lyase inhibitors and the androgen receptor inhibitors. But there was a study looking at patients who were treated with enzalutamide and did not respond, and what their potential mechanism of resistance was. And they were looking at something called the AR splice variant, ARV7. Tell us about that and what that means.
This work was led by Emmanuel Anantorakis out of Johns Hopkins. And splice variants are androgen receptor molecules that don't have the entire complement, and there are some missing pieces, in a sense, which may, in fact, allow some of those to be ligand independent, meaning they're constitutively active, even though there may not be dihydrotestosterone to bind.
So they lack the ligand binding domain?
Therefore, one of the things that's become very obvious as we've used abiraterone and enzalutamide is 20 to 25% of patients are primarily unresponsive to these drugs. Another 25 to 35% of patients have a transient response, and the rest will have a nice response. So the question is, why do people have de novo resistance? What happens in terms of acquired resistance? So this is a potential explanation for a subset of patients who may be resistant up front or maybe acquired resistance. It's unlikely that this splice, because there are multiple splice variants, this is a pretty common splice variant, there are going to be probably multiple mechanisms of different kinds that are going to ultimately come together in some patients to be the reason why you're not responding to this drug or you develop resistance. So this is just one of the early findings to say, here's a piece of data that suggests a mechanism. Now, this was obtained using circulating tumor cells, and the problem with that generalizability is that the amount of CTCs is somewhat dependent upon the technique you use. And in advanced disease, there's a higher frequency of CTCs. As we move these drugs into a earlier setting, the so-called pre-chemotherapy setting, measuring CTCs is not so easy. We rarely see them. So we're going to have to figure out other ways to make these determinations. But I think this is an important paper because it begins to highlight what we need to be thinking about in terms of resistance and how to use them as biomarkers to guide therapy.
So in the use of small molecule inhibitors like enzalutamide, in CML, resistance often comes about because of a change in the binding pocket. So is that a potential mechanism of resistance?
I think there is a myriad of potential resistance mechanisms to these agents. We're just now beginning to scratch the surface, but I think over the next year or two, you're going to see multiple reports of sort of basic science observations translated clinically to identify. And my guess is some patients may have multiple mechanisms of resistance. And the patients who have these profound, impressive responses, and we've all seen these patients who are on Abi or enzalutamide 3, 4, 5 years, their biology is different. So understanding what makes them versus these patients are going to be important.
It will. That's really interesting. Well, one of the novel agents coming down the line is ARN-509, and it's been proceeding through the clinical trials process and all. And this is another androgen receptor inhibitor. And there was a presentation today about patients who had metastatic castrate-resistant prostate cancer. Some of the patients have been exposed to abiraterone acetate, and some had not. And there appears to be a difference in the responsiveness.
Yeah, and I think, again, ARN-509, another very active next-generation AR antagonist, developed in the laboratories of Charles Sawyers, who helped develop enzalutamide. I don't think it's terribly surprising that we would see cross-resistance. We see cross-resistance with Abi and Enza. I think ARN-509, active molecule, has been demonstrated in a number of small trials, is also going to have a lower response rate in patients previously treated with one of those pathway drugs.
So, more to come.
More to come.
All right. So then the final thing in prostate I want to ask you about is there's been a tremendous amount of excitement at this meeting this year, especially in the hematologic malignancies with monoclonal antibody drug conjugates. brentuximab vedotin has been approved for Hodgkin's disease, and they all have a mitotic poison with a protease-sensitive linker linked to the antibody. And now there's an abstract here looking at a monoclonal antibody targeted to a prostate-specific membrane antigen with the typical monomethyl auristatin E poison linked to it. Does this have a significant future in prostate cancer?
It's an interesting compound, and as just to remind everybody, PSMA, unlike PSA, is a cell surface expression. I mean, part of the problem with targeting PSA is that the domain of the molecule goes both intracellularly and extracellularly. So PSMA has been a pretty interesting target for imaging and therapy. This molecule has been in development for some time. The initial set of studies were done in patients with more advanced disease, docetaxel failures. That MMA molecule has the potential to cause some neurotoxicity, and that was seen. So this experience now is a little earlier in better protoplasm type patients, and there clearly is anti-tumor activity. So this is sort of not only a dose finding, but a phase 1/2 trial to sort of to demonstrate some activity. Clearly mechanistically very different than the AR pathway drugs. One of the things I think we all understand is that going forward, we're not going to be able to target one target. So the ability to use non-AR targeting drugs like radium-223 or Sipuleucel T or perhaps PSMA ADC is going to be an important strategy. So it's a little premature to say whether or not we're going to be able to develop this forward, but there's unequivocally activity, and it seems to be safe enough to study further.
So is there documented understanding of the role of PSMA in the malignant prostate cancer cell? I mean, if it binds to a ligand, is it internalized and then stimulate proliferation and survival, or is it just sitting there on the cell doing nothing?
Well, I mean, PSMA is a very complicated molecule, but I think in terms of this study, it's the target. So as opposed to, and the payload obviously is the high volume Vinca inhibitory effect. So I think for this purpose, they're not relying on PSMA's ultimate utility, more as a very prostate-specific target.
So it's got to be internalized, release the toxin.
Correct.
Very good. All right. Well, let's move on to bladder cancer. And there was a presentation in this morning's session, a very long-awaited trial. Cora Sternberg gave this presentation of cystectomy in locally advanced transitional cell carcinoma of the bladder, whether or not patients should receive chemotherapy. So tell us about this trial that has taken 10 plus years to come to presentation.
Right. The Europeans, unfortunately, have blundered into the same problem that Americans have had in completing bladder cancer trials. And basically, what it really boils down to was an early adjuvant versus delayed at time of progression chemotherapy trial, dealer's choice, dose that's MVAC, GemCis, very European design of what you're most comfortable with. The trial was closed early because it was just not accruing appropriately. I think the way to look at this was that there was a trend to suggest that adjuvant therapy might be better, but there was no survival advantage. I interpret that trial as, unfortunately, yet another one of our trials that we didn't finish. I just remind people that we have level 1 evidence for cisplatin-based neoadjuvant chemotherapy, and that the adjuvant setting should not be utilized as a primary target. Granted, we see patients occasionally that have not received neoadjuvant therapy, have high-risk pathology, and we have, as a community, used adjuvant therapy, again, cisplatin-based therapy, as opposed to just giving any therapy. So I'm hopeful that that trial will be a legacy that we will forget, because you're going to ask me about something soon that I hope is going to replace it.
So frequently in our discussions, you have referred to bladder cancer as the low-hanging fruit. It's sitting out there waiting for the NCI or industry or whatever to pluck it out and do some effective studies. So at this year's meeting, like in the last several meetings here at ASCO, there's been a lot of work with the immune checkpoint inhibitors. And now there was a presentation with Genentech's anti-PD-L1 antibody, MPDL3280A. I'm very proud I can remember that.
I'm impressed.
But so PD-L1 seems to be somewhat of a biomarker in that the tumors that overexpress PD-L1 seem to do better with these immune checkpoint inhibitors, although sometimes some of the non-expressors also get a response, maybe not as durable, but they get a response. So how does this look in bladder cancer?
Well,
Is this going to be a player?
I will say that in urothelial cancer, those of us who've sort of labored in the field for a long time, we're very excited about this. There's unequivocal single-agent anti-tumor activity. Some of it is prolonged. It's tolerable therapy, and we all remember that these are patients who tend to be in their early 70s. Many of them have multiple comorbidities. Many of them have renal compromise. And this is a therapy that seems to be relatively well tolerated, and there's unequivocal single-agent activity, to which this particular compound has been anointed by the FDA for breakthrough designation. There's a large multi-cohort phase 2 trial that's it's actually open now, testing this compound in a number of settings of previously treated urothelial cancer. So I am, and again, I'm too old to be totally ecstatic, but I'm rather excited about the utility of this agent, and we need to get these trials done and understand the true utility. So I'm hopeful we finally turn the corner here.
So there are also the PD-1 antibodies.
And they're not far behind in terms of testing.
Nivolumab and
they will be,
MK-3475.
many of these agents we're going to also roll out in urothelial cancer. I mean, I think it's a surprising, unexpected perhaps, but very exciting demonstration of activity.
Very
so
good.
More to come.
Your associate, Brian Rinney, presented a paper at this year's meeting, an observational study in metastatic renal cell carcinoma, looking at a particular database, the CAPTURE database. Tell us about that and what the goals were. They were looking at patients with metastatic renal cell carcinoma who went untreated, who were just observed, and how long it took before they actually had to be treated.
Yeah. You and I were talking before we came on about what happened back in the day, since we practiced back in the day. And in kidney cancer, when we had biologics, interferon and conventional IL-2, with limited utility and not a whole lot of impact outside of that small group of high-dose IL-2 patients, that the first thing we did was to observe the natural history of the disease, because there was a subset, maybe 5, 10, 15% of patients, low-volume nodes, low-volume lung metastases, whose disease sort of just crept along, growing a millimeter every 3 months. And we were delighted, right? The disease allowed us to manage the patients without therapy. Well, those patients haven't gone away. I mean, what we did was we developed novel therapies, and certainly the TKIs and TOR inhibitors have been important. We don't cure anybody with those drugs. They're toxic. So this was a prospective collection of patients to identify patients who could be followed, and then at time of progression treated with the same kind of response rates that we would expect up front. So nothing particularly magical about this, but other than to remind us that sometimes the natural history of the disease allows you to manage a patient without having to use therapy. And until such time that the therapeutic paradigm changes, that when you're using toxic therapy, you could probably delay the use of toxic therapy. And I think that was a take-home message.
Right. I mean, years ago, there were many patients who would get focal radiation for a painful bone mat and observe their pulmonary lesions very, very slowly getting bigger.
And they're
but
still
they were
around.
fine.
And they're still around. Right. That's right.
Well, the other group of patients with metastatic renal cell carcinoma that may not necessarily be a candidate for some of the target agents are the young ECOG high performance people who may be candidates for IL-2. And there was a presentation going back and looking at a registry, the PROCLAIM registry, seeing how this group is doing. Because in the past we've always heard 10 to 15% maybe. It's really rough treatment, almost has to be done in the intensive care unit. But if you get a response, if you're one of the lucky ones, they're frequently durable. So tell us about this retrospective look
I think
over more recent times.
Yeah, what the registry basically tells us is there was probably a larger number of patients that respond, not dramatic, but more than historically believed. And the durability of the therapy is greater than we thought. So I think the take-home message from the registry, I mean, again, it's a registry and it's really just reporting, is to remind us that high-dose IL-2 still is the only therapy that has the potential to have sustained responses for long periods of time. I would remind people that high-dose IL-2 is not something to be done as a hobby. I've said this before with you, even at our institution, which is a big volume kidney cancer center, we actually don't administer high-dose IL-2. We send them to one of the centers of excellence, part of the high-dose IL-2 working group, because we want our patients to do well. We don't want to experiment. So given by folks with skills and the ability to manage the patients effectively, it's probably still an underutilized therapy that provides the potential for small but real numbers of patients to do well for a long time.
And they made the point that patients who got IL-2 as their first line of therapy seem to do much better than those who got it after 2 or 3
Oh, no
lines
question.
of treatment.
I think that, and that probably makes a lot of sense.
Sure.
If you're going to give a toxic therapy, you want to use it de novo. You want to give it early and see whether the utility is there.
Very good. And then finally, we talked about the anti-PD-L1 agent in bladder, but all of these anti-PD-1 and anti-PD-L1 agents are being looked at in renal cell carcinoma. And there was a paper today looking at nivolumab or nivolumab, however they pronounce it, Bristol Myers anti-PD-1 antibody that I think has been in trials the longest, but combining it with the anti-VEGFR TKIs, either pazopanib or sunitinib. How well is that combination tolerated? Are there any interactions? Does it boost effectiveness of either therapy? And how does this look?
Yeah, so these agents are, in addition to those combinations, there was an ipilimumab-nivo combination. The reality is these agents, these combinations are early. I think what we've learned is, yeah, there's more toxicity when you add them. They're acceptable toxicity levels. We don't optimally know duration, schedule, etc. We don't really even truly know yet whether or not there's additive or synergistic activity. So we're in the early phases. There are lots of trials with PD-1s in combination with pretty much all the frontline therapies.
Things, yeah.
There is a randomized trial that's ongoing comparing Nivo versus everolimus as a second-line phase 3 trial, and that trial is underway. So I think the reality is we're going to learn more about all these combinations. I think what we can say to date is there's clearly activity. The durability in some patients is impressive. In others, it's hard to see. It's complicated, unlike the urothelial situation where you give chemotherapy and that's what you got. Here we have multiple lines of therapy.
Right.
And trying to figure out how to introduce either this as a single agent or in combination is going to be more challenging. But I think many of us believe that there's going to be real activity here, and we're going to evolve our practice as we get more data.
Well, I think it's apparent that PD-L1 expression is a biomarker, but it still doesn't identify all the people who respond or all the people who don't respond. Some people with PD-L1 expression don't respond. So there have got to be other markers and other mechanisms that are yet to be discovered.
We have a lot to learn, and I think one of the discussants in one of the sessions made the point that relying on PD-1 or PD-L1 expression to make treatment decisions is probably not the right thing to do for exactly the reasons you suggested.
Right. Very good. Rob, thank you so much.
Thank you.
Always good to work with you. Hope you have safe travels home.
Thank you.
All right, and thanks to all of you for watching this segment of Best of the Day from the 50th annual meeting of the American Society of Clinical Oncology. Stay tuned. There's going to be much more from this year's meeting. Thanks a lot.